I'm honored to moderate this session. We have now today two distinguished speakers, and they will debate on are twins an adverse IVF outcome. We will hear for and against to twin or not to twin. And I'm inviting Professor Adashi to give his speech for twinning, or against twinning. Dr. Adashi is the former Dean of Medicine and Biological Science at Brown University, Providence, Rhode Island, and is currently Professor of Medical Science and of Obstetric and Gynecology, a member of the National Academy of Medicine, the Association of American Physicians, and American Association of the Advance of Science. Please.
Thank you very much. I assume we're all connected there in the back, and I hope you're hearing me all right. Thank you very much, Dr. Orvieto, Dr. Gleicher. Friends, let me begin by thanking the organizers for the opportunity and the privilege, and really to all of you, members of the audience, for electing to spend this time with us. Let me just take care of that. The question before us, first raised by Dr. Gleicher and his colleagues a decade ago, is an important one. In that initial paper, titled The Relative Myth of Elective Single Embryo Transfer, one published in 2006 in Human Reproduction, and in 6 subsequent contributions, Dr. Gleicher and his colleagues laid out the case against a blanket elective single embryo transfer policy. Throughout, they did so, in my mind, in a consistent and logical fashion. The latest contribution to this series saw press earlier this year in Reproductive Biology and Endocrinology. To the best of my knowledge, no other professional group in our field has challenged the notion of twin pregnancies and the notion that twin pregnancies must be avoided at all costs by the universal deployment of a single embryo transfer policy, or ESETS for short. None of this surprises me. After all, Dr. Gleicher has always been and remains an indefatigable, and if I may say so, indispensable contrarian, the likes of which we sorely lack in all disciplines, including ours. As many of us will be all too glad to acknowledge, original thinking is frequently in short supply. Had it not been for Dr. Gleicher and his colleagues, the nuanced elements of ESET versus DET, or the debate thereof, would have never come to light. Agree or disagree with Dr. Gleicher and his colleagues, I maintain that we are all the better for it. Before delving further into the question before us, let me also offer that I am hardly a model representative of the, quote, majority view on multiple birth in the modern era of fertility promotion, as the title of the debate suggests. Yes, I worked long and hard to attenuate the multiple birth epidemic that afflicted us by seeking to alter entrenched practice patterns. However, to the best of my recollection, never did I espouse a panoptic ESET policy or ruled out the prospect of a selective discretionary DET option if and when desired by a patient, absent medical contraindications. In other words, while my position is that E-sets are preferable when possible and agreed upon by provider and patient, selective DET must be seriously entertained if deemed more appropriate, not to mention desired by the patient. Patient autonomy, let alone prolonged infertility and advancing age, demand nothing less. At this point, it appears worth asking whether the United States is a fitting example of a blanket policy that insists on single embryo transfer. And I would argue not. The United States does not, at this time, pursue a blanket E-set policy. In fact, the latest ASRM guidelines on embryo transfer are hardly in that mode. While multiple nations overseas may well pursue a blanket E-set policy, that is not the case on these shores at this time. More on that later. Strictly speaking, this debate need not resolve the question whether or not twin pregnancies constitute an undesirable outcome of IVF. If that were to be the question, the answer would be clear. Twin pregnancy are best avoided, whether due to IVF or due to natural conception. Ours, after all, is a mono-ovulatory, uniparous species that is ill-suited to concurrent multiple progeny. We need not debate this question. Instead, this debate should be about the acceptability of twin pregnancies in the context of a discretionary double embryo transfer policy, which is to be applied if and when eligible patients wish to, or perhaps even should, pursue this route. This debate should also be about the defensibility of a rigid blanket single embryo transfer policy as distinct from a flexible, patient-centered, which makes room for discretionary DET when called for. In this context, the maternal and neonatal risks associated with a twin pregnancy must not be compared with those of an isolated singleton pregnancy, but rather with those of two consecutive ones. As I see it, the case against a blanket E-set policy, as framed by Dr. Gleicher and his colleagues, comprises the following arguments. First, a blanket E-set policy is paternalistic towards DET-eligible subjects who are pressed to conceive by prolonged infertility and/or age. Second, a blanket E-set policy is unethical towards DET-eligible subjects in whom successive E-sets could delay or preclude conception. Third, a blanket E-set policy is disadvantageous to DET-eligible subjects whose live birth rates may decline. Fourth, a blanket E-set policy is inconsiderate of DET-eligible subjects in whom successive E-sets could raise costs and efforts. And fifth, a blanket E-set policy is incapable of assuring a risk level that is lower than that displayed by twin pregnancies. Let us get started. It might be helpful to note that I'm in complete agreement with arguments number 1 and 2 of Dr. Gleicher and his colleagues, namely that a blanket ESET policy is paternalistic and unethical when applied to DET-eligible subjects. Such patients are likely to include, but need not be limited to, those who, in the absence of medical contraindications, prefer an accelerated approach to family building. Inevitably, such patients must also be deemed prepared to assume the maternal and neonatal risks associated with a multiple gestation. In general, such patients are likely to be older and/or afflicted with age-inappropriate ovarian function. What is more, such patients may also have previously experienced an IVF failure. Finally, I would argue that it is not beyond the realm of possibility that some of the patients in question may lack the means to embark on what could prove to be a long stretch of uncertainty. Such patients deserve a stab at a double embryo transfer. I am similarly in general agreement with argument number 3 of Dr. Gleicher and his colleagues to the effect that a blanket ESET policy is disadvantageous to DET-eligible subjects whose live birth rates may decline. Indeed, analyzed in isolation, the success rates of DETs are superior to those of ESET counterparts. For now at least, and for the foreseeable future, this conclusion appears unassailable. That said, in the context of young, good prognosis patients, the cumulative live birth rate of sequential sets is comparable, if not superior, to that effected by a single DET. Granted, such a route comes at a price, that is, successive ESET cycles, potential conception delay, and a modicum of uncertainty. To some, such cost of entry may be just what the doctor ordered. Others, however, would not hear of it, choosing instead to pursue the double embryo transfer route. With respect to the argument number 4 of Dr. Gleicher and his colleagues, I likewise generally concur with the notion that a blanket ESET policy is inconsiderate of DET-eligible subjects in whom successive elective single embryo transfers could raise the level of effort and perhaps cost. Note that I refrained from concluding that the ESET approach is more costly than its double embryo transfer counterpart, though I must say the truism of such assumption strikes me as intuitive. That said, it is my impression that the relative costs associated with a single DET versus sequential sets have yet to be thoroughly studied. At the very least, placing a question mark behind this element of the debate appears to be in order. A 2007 contribution by Hans Evers and his colleagues concluded, and I quote, that DET is the most expensive strategy, end quote. ESET in turn, and I quote, is only preferred from a cost-effectiveness point of view when performed in good prognosis patients and when frozen thawed cycles are included. A 2015 contribution by Crawford stated, and I quote, "The estimated total ART treatment and pregnancy infant associated medical costs were $580 million for 10,000 double embryo transfers started in 2012. If performed as sequential single embryo transfers, those estimated costs would have decreased by $195 million to $386 million, end quote. Clearly, more work could and should be done in this connection. My point is that it may be premature at this time to rely on cost considerations to either support or oppose the alternative approaches we are debating today. Finally, addressing argument number 5 of Dr. Gleicher and his colleagues, I remain unconvinced that a blanket ESET policy is incapable of assuring a risk level lower than that displayed by twin pregnancies. At least 2 published retrospective studies did in fact address themselves to this very comparison. In 2013, Antonin Sazanova cross-linked data from IVF clinics with the Swedish Medical Birth Registry to retrieve obstetrical outcomes. Data on severe neonatal morbidity were collected from the Medical Birth Registry and the National Patient Registry. As per the authors, and I quote, "The neonatal and maternal outcomes were dramatically better for women undergoing 2 IVF singleton pregnancies compared with 1 IVF twin pregnancy after double embryo transfer," end quote. Increased maternal risks included PPROM, preeclampsia, and cesarean section, but not placenta previa, placental abruption, or gestational diabetes. Increased neonatal risks included preterm birth, small for gestational age, respiratory complications, sepsis and jaundice, but not perinatal mortality, low APGAR, congenital anomalies, or mortality in the first year of life. In 2016, a second paper, this one by Giovanni Battista La Sala, concluded, and I quote, "The overall risk of perinatal complications was significantly higher in patients who had 1 twin delivery rather than patients who had 2 consecutive singleton deliveries," end quote. However, no difference between groups was detected for intrauterine fetal demise, neonatal health, perinatal mortality, and neonatal intensive care unit admission. Taken together, these papers also seem to suggest to me that additional work is required to clarify this facet of the debate. Here again, I would suggest that it may be premature at this time to rely on maternal and neonatal risk data to either support or oppose the alternative approaches under debate today. On December the 23rd, 2015, the Division of Vital Statistics of the National Centers for Health Statistics of the United States reported that the 2014 national twin birth rate has reached an all-time high of 33.9 per 1,000 live birth. The adverse consequences of rising national twin birth rate simply cannot be overstated. Notably, 11 and 59% of the twins comprising the 2014 cohort were born very preterm, which is under 32 weeks, and preterm, under 37 weeks. What is more, 10 and 55% of the twins in question were characterized as a very low birth weight, that is less than 1,500 grams, and low birth weight, or less than 2,500 grams, respectively. In a word, more than 1 of every 2 twins born in 2014 in the United States, 1 in every 2, was either preterm or low birth weight. A total of 18 states out of 50 registered twin birth rates in excess of the overall national figure. As recently as 2014, the last year for which reliable IVF data are available through the CDC, the declining contribution of IVF accounted for approximately 14% of the national twin birth rate. Improved as these circumstances may be, and it is, this is still not a pretty picture. We need to be thoughtful. The new ASRM guidance on the number of embryos to transfer, first floated on August the 8th of this year, calls for ESETs and DETs for patients 37 and younger with favorable and unfavorable prognosis, respectively. Patients 38 and older may receive up to 3 embryos per transfer. Only time will tell where these new guidelines actually take us. I would conclude by saying that in the United States, at least, flexibility still reigns supreme. There is no risk right now and not in the foreseeable future of a blanket single embryo transfer policy. Thank you very much.
So we'll take question after the next presentation, which will be held by Professor Gleicher.